everyone to another episode. Come on in, Doc. Come on in. Just make yourself comfortable there. Morning, everyone, to another episode here at Just Podiatry. Yesterday, obviously you guys don't know yet, but I will go ahead and post yesterday's case, a spitting image of what we're doing today. And you know, when we talk about heel pain, and you'll hear it also in the other on the other video. I'll post the other one first, so then I don't have to repeat myself today. But heel pain is very, very common. And when we talk about heel pain, it's not just plantar fasciitis, heel spur syndrome type pain. Heel pain can be posterior heel pain. And the two most commonly clinical presentations that we see in respect to heel pain is plantar fasciitis and Achilles tendonitis. Achilles tendonitis or Achilles tendinosis, or what we call Haglund's syndrome. That's something that I spoke a little bit on the other video, and you guys will see that as well. This young gentleman presented to our office recently with pain for 2 months. He did see another individual for care, and he was looking for something a little bit with more oomph. He came here to see us at Just Podiatry, and we recommended a percutaneous microtenotomy, a deep dry needling with PRP, to try to maximize his improvement and minimize any long-term complications, such as maybe some what we call intra-substance tears, right? Inside the tendon. Sometimes you can get these little micro tears of the tendon. And after that, then we're talking, as time goes by and it doesn't get any better, you can get these partial tears, real partial tears of the Achilles tendon. And then if not treated correctly, then you can really get into warm waters, right? So without further ado, let's proceed. This is the Achilles coming down, made up of two muscles, the gastrocnemius and the soleus. Come down here. There's a junction, if anyone is wondering. Pull back a little bit. Kevin Durant recently, for all the basketball players out there, or any NBA fans, he has recently sustained an Achilles tendon rupture, and it was in this area in what we call the junction, and he underwent surgery to fix it here, right? That's that'll cost him $250 million. But aside from that, the Achilles tendon comes down to here, and then this is the heel bone, the calcaneus. It inserts, it attaches in a fan-like, that's why I drew it like that, in a fan-like shape, fashion like this. And today we're gonna do, usually we stay in this area, but the patient was telling me that he's got a little bit of discomfort here, so we're gonna go ahead and also tenotomize that area. He may feel a little bit of discomfort. We already tested anesthesia, and like I've always said, again, he may feel a little. And I kind of just wiggle it like that sometimes, just to, I guess it's either, and you can, sometimes people can hear it, they can feel it. Let's see here. Sorry about that, bud. How you doing up there?
I'm fine.
Okay, and then we're gonna go to the other one. So then this is the area where it bothers him. So basically what we do is we go down to down all the way to the bone. We don't put, there you go. Once you get to the bone, boom, you come out, and then we go to the next one. Sometimes it falls through. It doesn't have to be so hard, very light. Good, and then we go to the next one. How you doing up there, bud? And then I'm gonna go ahead and just this is the area where it hurts him the most. Like right here. You can actually feel the celery, right? And then we're done here. So now we're gonna go ahead and come in with the liquid gold, so to speak, right? So we were able to isolate 3.3 cc's of plasma, about 30 cc, 20, yeah, it was like 24 cc's of blood. Okay, so what I'd like to do is Okay, bud, remember what I told you before? You may feel pressure, discomfort. If you do feel discomfort, just let me know and it'll stop. It's a dull, achy pain. It'll throb if you do feel it, and then it'll linger for about 5 to 7 minutes, okay? So what we'll do is we'll focus first on this area, okay? And I pre-bend the needle like that. And here we go. We go all the way in. That's why I pre-bend the needle. And then slowly, on the way out, we infiltrate. Here we go. How you doing up there? Good.
Does he feel mainly pressure?
He may, yeah, some people do, some people don't. It's all about just getting a really, really great block. That's the key, the block. Because there are nerves that are coming from the anterior, right?
So you're anterior to the tendon, close to the calcaneus.
Yeah, let's go this way now. You may feel, so I know I'm like here.
Mm-hmm.
Right, so here we go. You're doing great. Yeah, you can see it blanching already there. Into that area here. We stop here. We don't want to use it all there. And let's go over here. Over there. Aiming to that. You see it over there.
Mm-hmm.
What I'll finally do is I know that his discomfort is all of this here, right there. You don't want any of that plasma leaving the area. All of this here. I'm going to drop the rest here. It's going to blanch a lot here now. And we're all done. So
other than non-weight bearing, they can walk.
Right. So
their course.
The procedure's done. We have finished. As everyone can see here, now it's these little spotty areas that are white. That's where we delivered a little bit more of the PRP. Okay. So the purpose of let's just refresh everyone's memory. The purpose of the needling is to create more trauma. And if anyone is wondering, well, Dr. Wagner, why would you create more trauma, more inflammation? I mean, it's already inflamed, so why would you want to do that? And, you know, again, just like I was explaining to the patient, we want more, we want to trick the brain into believing there's a new injury, okay? How do we accomplish that? Exactly what we did today. So right now, we know that the brain is gonna be probably thinking, wait a second, there was nothing, everything was fine, and now it's not. So what happened down in the heel? The brain, body, there's going to be just a bomb rush of just blood to the area. Tendons, ligaments are very avascular. They have very little blood supply. So there's going to be an inflow of blood. That's what we want, right? The anti-inflammatory cascade. We also want important cells that are in the blood. But in addition to that, we also went and isolated the plasma. And then we delivered the plasma, the PRP, which contains the platelets, which contains the growth factors and all these important proteins, just to keep it simple. And we infiltrated the affected area here. Will help regenerate the affected Achilles in this particular case, and also reduce inflammation. This is the easy part. We call it the 90-10. 10% of what we do is today, and 90%, just to answer your question, is what he's going to do after. So, you know, patient selection is key. You know, we don't do these procedures on patients that we know that they're not going to be compliant, because the treatment is only as compliant as the patient is. Compliance is very important. He already has his Rolls Royce outside right here. He's got the knee rolling walker, and also the cam walker to answer your question. He's going to be immobilized for the first week, 1 week non-weight bearing using the knee rolling walker. I always recommend that if you can pull off of week 2, same thing, that would be great. And then week 3, no Rolls Royce, only the cam walker, the boot, and then eventual physical therapy. And if anyone is wondering, well, what about a second injection? If we can achieve a 60-70% improvement, and then it's kind of like this, patient is feeling better, and then we plateau maybe 2-3 months down the line, some patients will say, hey, do you mind, maybe we should do a second injection? I have no objections. I hope this has been an interesting case for everyone. Thank you for having other individuals in the room wanting to learn. Like always, www.jawspodiatry.com, Instagram, Dr. Tojam, Jaws Podiatry on Facebook, and our YouTube channel, Jaws Healthcare. For all the viewers out there that have not taken a look at our Facebook page, I highly, highly recommend that you do. I've said it before, there are things that we don't post on Facebook that we do on YouTube, and YouTube that are on Facebook, and I think that you'll enjoy. It's a more interactive experience. Just type in Jaws Podiatry, it'll come up.